Moving on to day 2 of our 70-day plan to prepare you for the GPhC registration assessment. So following on from day 1, you should have familiarity with the GPhC registration assessment framework. We've gone through that in the webinar recording from day 1. And now I want to focus on 2 of the high weighting topics, 1 being infection and 2 being the endocrine system. There are 2 webinar recordings that we have on the MicroPharm platform. I'm also going to include them in this video. So following on from what I say, we're going to get started on infection and endocrine system. There are 4 high weighting topics for the GPhC registration assessment: infection, endocrine system, CNS, and cardiovascular system. So these are 2 of the 4. These are the 2 areas that I teach on for the platform. We have a team of 16 clinical educators, and you'll see more of those clinical educators in subsequent videos. I also want you to go through the calculations module 1. The calculation module 1 on the platform includes 12 videos by Enketia, our lead clinical educator for calculations, where he has 1 example for each type of calculation question that you can get in the exam. There are 12 in total. In this video, I'm going to include 2 of those videos. If you are a member, you have access to all 12. If you're a member, you have access to 70 videos in total. So I would like you to watch these first 2 webinars, so Introduction to Infection and Endocrine System, and to complete module 1 of the calculations. What I want you to do, and Kesia will repeat this, is I want you to attempt the question before he gives you the answer, and then go through his working out. So hopefully you get on well with this, and I will see you in the next video on day 3. Okay, so we will start with today's session. Okay, let's start with today's session. So today is an introduction to the infection chapter. The infection chapter, people generally tend to struggle with the infection chapter. And the reason for that, I believe, is because there's this sort of multi-factored approach when it comes to the infection chapter. First of all, with anything that you're revising, you need to know the different medications within a particular chapter and the reasons why they are used. You've got this added complexity in the infection chapter with regards to understanding the microbiology. So it's this essentially this added complexity, and this added complexity with regards to the infection chapter determines your treatment options when it comes to what should you be treating a particular patient or a particular infection with. So just those multiple factors is what I feel like tends to scare trainee pharmacists quite a bit. Just to give you a background of my role within infection, currently I work within the interstitial lung disease department, but I worked as an antimicrobial pharmacist for 3 years prior to this role. And then following on from my antimicrobial pharmacist role, I worked within infectious diseases and HIV for about 6 to 7 months before I started this role. Currently, my teaching areas as a senior lecturer for undergraduate students is infection. So I still actively teach in infection. And I'm also a visiting lecturer and marker for the postgraduate antimicrobial resistance module. So anyone that's already a qualified pharmacist that's doing their diploma, their postgraduate diploma in clinical pharmacy, if they're picking the antimicrobial resistance module, I will generally either be marking those papers or moderating for that postgraduate diploma. So has everyone taken a look at the MicroPharm Pro roadmap for this year? Yes, so the roadmap is essentially one thing that's extremely difficult is when you've got such a large library of information with your pro membership, you sometimes don't know where to start. So, what I thought would be useful is to give you some guidance on where to start. And what I've done with this roadmap, this is the first time we've done a roadmap like this, is I've provided you with, I've broken it down into months. That's the first thing. And then I've also told you which webinars we are going to run in particular months. So, of course, it's August right now. So I'm doing the introduction to the GPhC exam webinar that was last week. And I'm going to upload that to your online platform this week. And also the introduction to the infection chapter webinar, which is today. But I've also got some recommendations of what modules I think would be useful for you to watch. And I've provided a monthly breakdown of what I think you should be watching in this particular month. And then also I give you information on so what I think you should be watching for this month, and also the webinars that we're going to run over this month. So what's the aim of today's session? So the aim is to provide you an introduction to the infection chapter in accordance with the BNF. I'm also going to talk about considerations when it comes to prescribing antibiotics. And today we're going to go through high-risk antibiotics. So, like I said to you, the infection chapter is extremely difficult when it comes to looking at just the different complexities of microbiology and also which antibiotics are appropriate for treating a particular infection. And what can tend to happen is the guidelines will change in accordance with resistance patterns. So we're used to see, let's say 5 to 10 years ago, the first line treatment would always be trimethoprim for a lower urinary tract infection. Now we hold back a bit on the use of trimethoprim, particularly because of resistance. And in many hospital trusts, nitrofurantoin is used more often because of resistance patterns. So I'm going to ask you quite a few questions today. We're going to make it as interactive as possible. And by doing it in the story format, hopefully you can absorb the information more easily. So you've got Ben, who's tested positive for COVID. Should Ben receive antibiotics? What do we think? Yep, so a relatively easy question to get started with. But a very good point in the comment section is the fact that there is a circumstance where Ben could or may need antibiotics, and that's if there's evidence of a secondary bacterial infection. What does it mean for it? What is a secondary bacterial infection? So it absolutely. So it starts as a viral infection, and then due to the fact that the patient has that initial viral infection, puts them at risk of a bacterial infection. So Ben, for example, could develop a bacterial infection on top of that initial viral infection, and that's where it may be appropriate for him to receive antibiotics. Does anyone know the rough percentage of secondary bacterial infections with COVID? Roughly about 8%. So very low in terms, and this is for those that are tested. So bearing in mind, a lot of people are not tested at all. So yes, a very low percentage. Not all patients need antibiotics, as you probably know from all your experience of working through COVID. Terry has been admitted to the emergency department with sepsis of unknown origin. What should the medical team do before giving antibiotics? There's a lot of different considerations here. Take a culture for culture and sensitivity testing? Absolutely. When is it important to take the culture? So when they come through the door, what's the absolute first thing? So are we saying cultures and sensitivities? before antibiotics. Why is it very important to take those cultures before antibiotics? What sort of antibiotics do you think we're going to give to Kerry? Yes, so the likelihood is we're going to give a broad spectrum antibiotic. What does broad spectrum mean? It means it covers a lot of different organisms, most gram-positive and gram-negative organisms, particularly with when we give the broader spectrum antibiotics to patients with sepsis of unknown origin. What that means is if you're covering a lot of those organisms and then you take a culture, your likelihood of identifying that organism that's causing the infection is reduced because of the fact that you may be treating that organism and therefore it doesn't grow when you take culture and sensitivity testing. So very important to take that into consideration. Does everyone understand that point before I move on? Yes. Okay. So absolutely. So you take samples for microbiology, culture, and sensitivity testing. Raheem is a pharmacy student on his placement. He wants to learn more about spectrum activity. Why do we prefer narrow spectrum antibiotics over broad spectrum antibiotics? Yeah, so there's a lot of people are referring to resistance. So what do we mean by issues of resistance? Why is there a reduced likelihood? Absolutely. As someone mentioned, it doesn't kill the healthy bacteria, and therefore there's a reduced likelihood of you developing resistance. You're more likely to direct your activity to the organisms that are causing the problem, that are likely causing the infection. You're less, there's a few different factors. You're less likely to disturb your normal flora, so your normal organisms that normally reside within your gut, for example. If you're less likely to disturb those organisms, what do you think you're reducing the likelihood of as well? Yeah, you're reducing the likelihood of C. difficile as well. So you're reducing the likelihood of side effects, and you're also reducing the likelihood of resistance. If you're having an impact on other organisms, you are inherently increasing the risk of you identifying resistant organisms. Does everyone understand how broad spectrum antibiotics can increase the risk of C. diff? Does anyone not understand? And do they want me to explain? Yeah, okay, let's explain. So when you've got your gut, you've got millions of different organisms within your gut. I'm going to really simplify this. So if you have broad spectrum antibiotics, let's say they kill 95% of the bacteria within your gut. Many of the antibiotics that we currently use on the market don't have activity against C. difficile. If you're killing 95% of the organisms and C. difficile remains, why is that a problem? Absolutely. So someone's put in the chat less competition. So there's less competition for nutrients. The organisms that you have, which is called your gut microflora, there's this harmony and balance with regards to resources and nutrients within the gut, and this means that there's due to this perfect balance, you're less likely to have side effects associated to the overgrowth of one particular organism. When there's way less competition, C. difficile can overgrow, can thrive, has less competition with nutrients. And what C. diff can do when there's overgrowth, it can infect, it can start to attack that gut lining. And by doing so, it can cause a C. difficile infection. Patients can experience several watery bouts of diarrhea, and C. difficile can become life-threatening if it's untreated. So When you're going to start treating a patient with an antibacterial, so an antibiotic, what patient factors do you need to take into consideration? Let's consider the patient's allergy status, because of course that will determine which antibiotics they will receive. What about their kidney function, their liver function? In some cases, can impact what you're going to use, their age, their weight, the severity of the infection. There are so many different factors to consider. So, like I said to you, you've got different points. The renal function. Where do you think? When do you think the renal function matters? So drugs that are renally cleared, absolutely. If you've got poor renal function, that inability to remove, if medications are removed from your body via the kidneys and you've got poor renal function, that means more of that medication can accumulate. More of the medication, increased risk of side effects. Liver function, if the liver function is impaired, sometimes medications are metabolized by the liver. That liver impairment can cause problems with regards to metabolizing those medications. Again, increased risk of accumulation. Age can sometimes be a factor when it comes to providing antibiotics. Weight can sometimes be a factor. Allergy status, of course, if a patient's allergic to a medication, you will have to give an alternative. What factors would determine the route of administration? Okay, so someone's right on the ball. Severity, absolutely, Sally. Severity of the infection is extremely important. Let's talk about flucloxacillin, for example. Um, how how do we alter essentially the route of administration in accordance with severity here? Which infection do you think I'm referring to? No, so the particular type of infection rather than the bacteria. No, what do we normally use flucloxacillin for? Absolutely. As someone's put in a direct message, cellulitis. Absolutely. We use flucloxacillin for cellulitis. It has relatively narrow spectrum of activity. It has great activity against Staphylococcus aureus, which generally causes cellulitis. Um, in terms of its route of administration, if you've got a severe case of cellulitis, you can use flucloxacillin intravenously. Why is it beneficial to use an antibiotic intravenously? You have absolute bioavailability, 100% bioavailability. If you're giving it orally, your bioavailability is greatly reduced. You have a faster onset of action and increased bioavailability. These are crucial when it comes to giving an antibiotic rapidly for a severe infection. But now let's go through high-risk antibiotics. So aminoglycosides, can you name examples of aminoglycosides? Amikacin, gentamicin, absolutely. Amikacin, gentamicin, neomycin, streptomycin, and tobramycin are the five examples that you need to remember. Gentamicin is the most commonly prescribed aminoglycoside in the UK. Which there are similarities with other types of antibiotics, and the mycin at the end doesn't necessarily always mean it's an aminoglycoside. Azithromycin, clarithromycin, and erythromycin all belong to another class of antibiotics. Which class is that? Macrolides. So it's important not to confuse macrolides with aminoglycosides. So that rule of the mycin at the end isn't the case with only aminoglycosides. You also have an example of vancomycin. Which antibiotic class does vancomycin belong to? Anyone? Vancomycin. We'll go through it later. So, how do aminoglycosides work, and which bacteria do they work against? Mostly gram negative. So its activity is mostly against gram negative. Does anyone know how they work? Yep, they inhibit protein synthesis. So they bind irreversibly to the bacterial ribosome, and by doing so, they inhibit the production of protein. They lead to the production of abnormal or non-functional proteins. The majority of their activity is against gram-negative organisms. The only gram-positive organism that it's effective against is Staphylococcus aureus, and in turn MRSA as well. So methicillin-resistant Staphylococcus aureus, which is also Staphylococcus aureus. It's just more resistant. The reason why it's active against Staphylococcus aureus only from the gram-positive organisms is it needs to use an oxygen-dependent transport system to make its way into the organism. Why does it need to make its way into the organism? Because it then needs to make its way to the bacterial ribosome and to prevent and inhibit protein synthesis. Now, it needs this oxygen-dependent transport system on the wall of bacteria to make its way in. That oxygen-dependent transport system from all gram-positive organisms is only found on Staphylococcus aureus. And then the rest of its activity is against many gram-negative organisms. It namely has good activity against Pseudomonas as well, which provides it which is one of the main reasons why it can be used in terms of its spectrum of activity. But like I said to you, active against some gram-positive bacteria and most gram-negative bacteria. Can you name some indications, some reasons for when it would be used? What types of infections am I referring to? So let's talk about the particular types of infection before we talk about the organism. And then I will start to talk about the organisms. So may be used for sepsis, particularly if you need coverage against either MRSA or Pseudomonas. It could be used for sepsis of the urinary tract. It can be used for diabetic foot infections. Particularly, this is because of its Pseudomonas activity. So can be some of the most common are infective endocarditis, meningitis, and hospital-acquired pneumonia. In infective endocarditis, one of the useful things is the fact that it has great activity against Staphylococcus aureus, which is that gram-positive bacteria the only gram-positive bacteria it has activity against, because Staphylococcus aureus tends to cause infective endocarditis. It's one of the most common organisms of causing infective endocarditis. It's active against meningitis. It's used for meningitis. It's also used for hospital-acquired pneumonia. The reason why it's used more so for hospital-acquired pneumonia rather than community-acquired pneumonia is because hospital-acquired pneumonia, Pseudomonas can cause hospital-acquired pneumonia. The reason why Pseudomonas tends to cause more of a problem here rather than community-acquired is because Pseudomonas can generally be found in a hospital setting, so it increases the patient's risk of them having a pneumonia caused by Pseudomonas. So generally, you won't see aminoglycosides used very much for community-acquired pneumonia unless there's evidence of Pseudomonas. So Joyce has been prescribed gentamicin for the treatment of infective endocarditis. Abdul, the junior doctor, wants to know the possible side effects of gentamicin. What are you going to tell Abdul? Ototoxicity. So there's a risk of hearing loss. It can cause irreversible ototoxicity. Any damage that occurs to the patient's hearing is irreversible. It can either demonstrate in two ways. There could be hearing loss, or there could be ringing in the ears, which is tinnitus. What else in terms of side effects? Nephrotoxicity as well. So possibility of diarrhea, gastrointestinal issues, nephrotoxicity. The nephrotoxicity associated with gentamicin is reversible. So important to know that. The nephrotoxicity, ototoxicity, it can cause peripheral neuropathy, and it can also cause electrolyte disturbances. Glycopeptides. Can anyone give me examples of glycopeptides? Yeah, so we've got vancomycin, ticaplanin, telavancin, and dalbavancin are four examples. The most commonly used are vancomycin and ticaplanin. Dalbavancin is a relatively new antibiotic. It's starting to be used more often, and it's starting to be used more often. The usefulness of dalbavancin, it has this really long half-life of approximately 7 days. Another relatively new glycopeptide on the market is oritavancin as well, which also has a very long half-life, like dalbavancin. The most commonly prescribed in the UK is, of course, vancomycin. So how do they work, and which bacteria do they work against? So all of the activity is against gram-positive bacteria only. Um, so there's no activity against gram-negative bacteria at all, and they inhibit cell wall synthesis. They do this in a different way to penicillins, but also penicillins also inhibit cell wall synthesis as well. So sometimes one of the considerations when you're giving an antibiotic is you don't want to give it alongside another medication, a high-risk antibiotic, for example, like a glycopeptide and aminoglycoside. You don't want to give it alongside another antibiotic or another medication that can also cause that severe reaction. So, for example, if you've got an ototoxic drug like vancomycin, you don't want to give it alongside another ototoxic drug. There are some circumstances where you'd give vancomycin and gentamicin together. Which circumstance do you think, which infection do you think you could use both of them together? And has anyone seen this happen in practice? This this knowledge is possibly beyond the assessment, so I'll just go through it with you, just to give you some background understanding. Sometimes you may see, if you work in a hospital setting, you may see gentamicin and vancomycin used for infective endocarditis. And this is because they have a synergistic effect. So the vancomycin inhibits cell wall synthesis, so it inhibits formation of the cell wall, and it can make it easier for other antibiotics to enter via the cell wall. So therefore, this can make it easier for the gentamicin to get in to the bacteria, and then it makes it easier for that gentamicin to inhibit the production of proteins by making its way to the ribosomes. So that's why it has a synergistic effect. They both can work very well together. So they inhibit bacterial cell wall synthesis. They target the peptidoglycan layer of the cell wall, and this, of course, provides structural support and protection for the bacteria. It's gram-positive only. So can you name reasons, some indications for glycopeptide usage? They can be used for C. difficile infections. Which route of administration would it be if you're using a glycopeptide for C. difficile infection? Oral only. Why can you not give it IV? It acts locally within the gut. It's a very large molecule. It won't be absorbed from the gut. Therefore, if you're giving it intravenously, it won't be able to make its way into the gut. So it has to be given orally where it can reach the gut. Yep. So infective endocarditis, like I mentioned before, C. difficile, which we mentioned, it's used orally when used for the treatment of C. difficile, and it can be used for glycopeptides can be used for hospital or community acquired pneumonia. If you're using glycopeptides for C. difficile, the main glycopeptide you're going to be using, in accordance with guidelines as well, is vancomycin. You're going to be giving the vancomycin orally. Ahmed has been prescribed vancomycin for diabetic foot infection. What side effects should the medical team monitor for with regards to vancomycin? Yep. What is red band syndrome and what increases the likelihood of red band syndrome? If you see the term vancomycin infusion reaction, this term is used interchangeably with Redman syndrome, and this is associated with the speed at which you infuse the vancomycin. So if it's infused rapidly, if it's given too quickly, as people are mentioning, then that increases the risk of Redman syndrome, where you've got this hypersensitivity reaction of the upper body, and you've got this entire redness of the upper body, which can occur with patients. It can also cause blood disorders, so it's very important to monitor patients' blood counts. It can cause thrombocytopenia, so a drastic reduction in platelet counts as well. And what other side effects should we be monitoring for? Some we've already mentioned. Nephrotoxicity and ototoxicity as well, absolutely. So nephrotoxicity, ototoxicity, vancomycin infusion reaction, which is also Redman syndrome, and blood disorders. It can drop platelet counts. In terms of blood disorders, what would you tell a patient to look out for? How may a patient see this. Unusual bleeding or bruising. Yes, absolutely. So sore throat may also be a sign of immunosuppression. Bleeding gums, bleeding via urine. Absolutely, very important to counsel patients on what they may see with regards to these adverse effects. Okay, so now we're going to go through. Okay, so today we're going through the endocrine system. So the endocrine system, when it comes to the GPhC exam, is it low, medium, or high weighting? Does everyone know? Absolutely, high weighting. What does high weighting actually mean? What percentage of the assessment will high weighting material make up? No, higher than that, Julia. So it surprises a lot of people. 60 to 70% of the assessment is made up of high weighting material. That's very important when it comes to your studies. So what proportion of your studies should be focusing on high weighting material? 60 to 70%. It should be the amount of time you spend understanding and being confident on a particular topic should correlate with how much of the assessment it actually makes up. Sounds like common sense. I see people do different to that. So often I lose count. So make sure you know your high weighting topics the best, which therapeutic areas fall under high weighting material. Cardiovascular system, absolutely. Central nervous system. Respiratory is medium weighting, infection, and endocrine system. So the four are the cardiovascular system, endocrine system, infection, and the central nervous system. Okay, so what's the aim of today's session? I want to introduce you to diabetes mellitus. Of course, from your undergraduate studies, you should be very confident and have a good understanding of diabetes mellitus. If it's a bit rusty, absolutely no problem, but it tends to be one of those topics people find easier to pick up compared to others. How do people find insulin? What about insulin? Do you find that difficult to understand? Can be quite confusing. Yeah, it can be quite confusing. So for those of you who don't know, I've been a type 1 diabetic since 2001. So that gives me a bit of an advantage. I've also taught diabetes to undergraduate students as well. So I've taught diabetes to undergraduate students, and I manage patients with diabetic foot infections in clinic. I'll give you a brief overview of my role and my background for those of you who don't know. So I currently work as a senior lecturer in pharmacy practice. So I teach pharmacy undergraduate students. I also work for the postgraduate diploma. I work for marking for the antimicrobial resistance module. I support with that. I'm also, half my week, I work as an advanced specialist pharmacist. Currently, I work in the department where I manage patients with interstitial lung disease. I have a strong background in antimicrobials and infectious diseases. So I worked as an antimicrobial pharmacist and also an infectious disease pharmacist for 4 years. So where does my background come for the endocrine system? Well, I've taught over 600 students that are undergraduates diabetes when it comes to university level. I also taught for the endocrine system for 3 years via MicroPharm. So it's one of my strong areas. So let me introduce you to diabetes mellitus. So diabetes mellitus is a group of metabolic disorders in which you've got persistent hyperglycemia caused by deficiency in insulin secretion or resistance to the action of insulin. So Diabetes, you've obviously got the possibility of two types. What's the main difference between the two types of diabetes? Type 1 and type 2. In terms of the most common classifications, what are the main differences? Yes, Julia. For type 1 diabetes, your body doesn't make any insulin. My body doesn't make any insulin at all. I'll just move myself to the side. For type 2 diabetes, the patient can produce insulin. They can sometimes produce less, or they have problems with the receptors on their cells not recognizing the insulin that's there. So this leads, of course, it leads to abnormalities in carbohydrates, fat, and protein metabolism. If you consider sugars that are released from your foods in your blood, insulin is the key. It's the key to your cells that allow the carbohydrates and the sugars to be absorbed into those cells. So it's extremely important to have either the sufficient amount of insulin being produced and also for the insulin to be recognized appropriately, because this determines your blood glucose levels. And of course, if you have abnormalities with that, patients with diabetes mellitus have a higher blood glucose level. The two most common classifications of diabetes are type 1 and type 2. Other types of diabetes are secondary diabetes. So what do I mean by secondary diabetes? Anytime you see the term in medical terminology where you see the term secondary diabetes, it means it's happening as a result of something else. So an example of that is acute pancreatitis can lead to secondary diabetes. Why do you think that occurs? What do you think is happening there? Yeah, so the pancreas makes the insulin, absolutely. So acute pancreatitis is inflammation, so damage to the pancreas. And therefore, if you've got acute pancreatitis, you can damage the islets of Langerhans, which produce the insulin in the pancreas. You've got gestational diabetes, which of course happens during pregnancy. What can happen with gestational diabetes is often patients with gestational diabetes are tested following the delivery of the baby to see if they still have symptoms of diabetes. In most cases, this should resolve following on from them giving birth. All drivers who are treated with insulin must inform the DVLA. So when I say all drivers, am I that are treated with insulin, am I relating this to patients with type 1 diabetes only or type 1 and type 2 diabetes? Both, absolutely. Because there's a risk of them being treated with insulin of what? What's the risk if someone's having insulin constantly? Risk of hypoglycemia. So hypoglycemia being your low blood glucose levels, there's a risk of this. There's essentially a risk of this if patients are being treated with insulin. If drivers are being treated with insulin, they should carry a blood glucose meter or blood glucose strips, or they could use the continuous glucose monitor, and they should check their blood glucose readings no more than 2 hours before driving and every 2 hours when driving. What should a patient's blood glucose levels be before they drive? When would you say it's safe for you to drive? At least 5 millimoles per liter. Absolutely. So the aim when you're treating someone with type 1 diabetes, so focusing on type 1 diabetes, is to use an insulin regimen that achieves optimal control of a patient's blood glucose readings. Ideally, you want the HbA1c concentration to be 48 millimoles per mole. And if you're using the old units, that's 6.5% or lower is recommended in patients with type 1 diabetes. They should be monitored. So readings of your blood glucose reading should be monitored at least 4 times a day, including before each meal and before bed. Quite a lot of type 1 diabetics and all that type 1 diabetics are actually recommended to have a continuous glucose monitor now. And the continuous glucose monitor allows them to have readings every 5 minutes. So it's drastically changed. The way we manage diabetes has drastically changed. So why is it important? Why is it particularly important before testing your blood glucose readings before each meal and before bed? Why before each meal? So let's start with that. Why is that important? Yeah. So you give yourself the right amount of insulin. So if your blood glucose level is higher than it should be, then you need to give insulin to reduce that. And then you have to take into account the insulin that you're going to inject for the carbohydrates in a meal. So it's very important to have an understanding of where you are before you give your injection, because that determines how much injection you actually give. And when I'm saying this, I'm referring to the basal bolus regimen, which I'll go through in later slides, which is the gold standard when it comes to managing type 1 diabetes treatment. In terms of aims, so in terms of before bed, think of that entire window whilst you're asleep. You want your blood glucose levels to be in control. So that's why it's extremely important to check your glucose readings before bed. So in terms of targets, if you're fasting, you want a target between 5 to 7 millimoles per liter. If it's before meals, you want it between 4 to 7 millimoles per liter. If it's 90 minutes after eating, it's between 5 to 9 millimoles per liter. There's an increased leeway after eating because your body's now absorbing the carbohydrates and the insulin is kicking in. When it comes to fasting on waking, the threshold, the target is slightly higher. And that's because you don't want people going for a target of 4 whilst they're sleeping. You have the risk of something called a nocturnal hypoglycemia. All that means is having a hypoglycemic event during your sleep. There is a risk of death if patients have hypoglycemia in their sleep and it's not treated. So it's extremely important to ensure people aren't floating at lower levels or going for lower targets whilst they're sleeping. And like we said before driving, at least 5 millimoles per liter. So in terms of insulin therapy, the gold standard is a basal bolus insulin regimen. What is a basal bolus insulin regimen? Yeah, that's a great question. Once people answer this question, Saweed, I'll answer your question. Yep, your basal is your background insulin. Your bolus is your mealtime insulin. What are you trying to do here? You're trying to mimic what the body's actually doing. Your body produces, a healthy body without diabetes mellitus will produce a small amount of background insulin when you're not eating and will produce mealtime insulin when you are eating. Saweeda asked the question, how do you calculate how much to give based on your meals? Are there apps? So there are several apps when it comes to things like this. The most important thing is there's a comprehensive course provided by the NHS, which is called the DAFNE course, which means Dose Adjustment for Normal Eating. But the basis behind the DAFNE course is you look at how many grams of carbohydrates there are in a meal, and you determine how many units you need per 10 grams of carbohydrates. Now, there's no blanket rule for that. And the reason why there's no blanket rule is for every 10 grams of carbohydrate I eat, I give myself 1 unit of FIASP insulin, and we'll go through the different types of insulin. But sometimes some patients have a 2-to-1 ratio. And what that means is for every 10 grams of carbohydrates they eat, they need 2 units of insulin. And that changes for different types of bodies, and you have to take into account the amount of body fat a patient has. You have to take into account patient's metabolism. What you tend to find is it's it's difficult. You tend to find patients that are underweight requiring less insulin for their meals, but it changes from patient to patient. So we spoke about basal bolus regimens. We also have mixed biphasic insulin regimens. What are mixed biphasic insulin regimens? Short acting, they tend to be a mixture of two different types of insulin, correct? It tends to be short acting and intermediate acting together. And that's why often mixed biphasic insulins, as the name suggests, it's given twice daily. So it's given twice daily. So the biphasic should lead you on to thinking there's some intermediate acting insulin involved, because intermediate acting insulin is given twice daily. And it has a combination. It has a proportion of short-acting insulin, which is your mealtime insulin, and it also has your intermediate-acting insulin, which is your background insulin. When do you think you advise patients to take these injections? What do you say about meals? With food, as the short acting is included, absolutely. So a common mistake a patient can make, particularly when they're newly diagnosed, is not taking it with food. The short acting side will act very quickly, relatively to the intermediate acting side. So its onset of action is about 15 to 30 minutes. It'll be about, it's dependent on the type of insulin that's in the mix. So onset of action will be about 5 to 15 minutes. If it's rapid acting insulin, it can be 30 to 60 minutes when it's a short acting insulin. And then you have a continuous subcutaneous insulin infusion, which is an insulin pump. So when we're talking about insulin pumps, how many types of insulins are included in an insulin pump? Yes, Julia, one. How do you think that insulin is given? Bolus when eating, yes. So it's a combination. There's a bolus. You can bolus when eating. So you tell your pump how much insulin to give when you're going to eat. And also you have your background, which is you can determine your background. So you give a small amount of rapid acting insulin every hour. So mine will be like, let's look at how much insulin I'm receiving this hour whilst I'm speaking to you. My basal is I'm receiving 0.5 units of rapid acting insulin this particular hour. So between 9 and 8 p.m. And that differs from patient to patient. The beauty of your insulin pump is you can change how much insulin you require depending on which time of the day it is. Patients with type 1 diabetes should be offered multiple daily injections, so a basal bolus regimen as a first-line choice. Why is that important? Yes, better control is the premise behind that. What do you mean by better control? Can you expand on that, Julia? Yeah, more similar to how the body works, but we have to talk about something extremely important. What's the main disadvantage of a mixed biphasic insulin regimen? What do you think? So I went through how a mixed biphasic regimen works. What do you think the main problem is with that regimen? Possibly, there's a risk of high, but if a patient's having it with mealtime insulin, it's no different to a basal bolus. Not because of how quickly the short acting works, because you're in a basal bolus, your rapid acting works faster. We're assuming something huge about all patients here. What are we assuming? Not everyone is the same, and also what else? It's someone's put it in the private chat. We eat. Have you had a day where you well, maybe you've had 2 days where you've ate exactly the same amount of carbohydrates, but how often are we going to eat the same amount of carbs every day? The fact that we're making a sweeping statement that sweeping statement and assumption that patients have the same amount of carbohydrates every day is, to me, it's ridiculous. And that's exactly what we're doing with patients that have a biphasic insulin regimen. We're assuming have the same amount of carbs every day because you're giving them exactly the same amount of short-acting insulin every day, and that's where the terrible control comes in with a biphasic insulin regimen. The beauty of a basal bolus is your background, your basal will stay the same. Your bolus, your mealtime insulin, you change it for the amount of carbs that you're actually having in that meal. So patients with type 1 diabetes mellitus should be offered a basal bolus. The first line is twice daily insulin detamir. Why do we say twice daily insulin detamir rather than once daily? What type of insulin is insulin detamir? It's a long-acting insulin. How often do we give long-acting insulins? How many times a day? We've got one person's directly messaged me to say it's at night. One person has said once daily. So generally once a day. Why are we saying twice daily for insulin detamir? And that's in the BNF. So you will see that in the BNF. So don't isn't that sort of counterintuitive, counterproductive? What do we think? I think these are important points to consider so you can actually remember them for the assessment. Does anyone hazard a guess? More more extreme rise in glucose? Possibly, possibly. What does this relate to? Yes, so we're getting there. So if you're considering the duration of action for the insulin, so insulin detamir has a lower duration of action compared to other long-acting insulins. After 20 hours, its effects start to taper off. So we'll look at that on a graph. And because of that, you want better coverage by splitting the dose. You've also got better flexibility with giving patients a higher dose at night, for example, and a lower dose when they take their morning insulin. And that gives you some level of flexibility. If they can't have that, then you can give once daily insulin glargine. And if they can't have once daily insulin glargine, then you can give once daily detamir. So twice daily detamir, your first line. What's the brand name for detamir? Levemir, absolutely, yep. And the name should help you with that. What about insulin glargine? What's the brand name for insulin glargine? Lantus is your most common example. There are other brands on the market now, like Semglee. Also, leading to onto my next question, how many times a day for Lantus, if you are recommending it to a patient? Once daily, absolutely. It's once daily. And then if they can't have that, then it's once daily of insulin detamir. So Mrs. Williams takes Nova Rapid for her mealtime insulin. She is due to eat breakfast. When should she take her insulin for breakfast? Okay, I've got one person to say 10 minutes before, one person saying 30 minutes before, and one person saying directly before she eats. Okay, let's put a poll. Just bear with me. So A for directly before she eats, B for 10 minutes before, C for 30 minutes before. So what I'm going to do soon, we're going to go through the next few slides and then we'll end this session here because I've got another session coming up later on in the month where we're going to go through, where I want to go through insulins more comprehensively. So I think that would be a good idea because I really I underestimated how long it would take just to go through the introduction. And I'm just halfway through my slides for today. So what I'll do is we'll go through some more of these questions to understand types of insulin, and then we'll have a dedicated webinar for insulin that I will make free for all users. Okay, so got a bit of we've got half of you saying directly before she eats, half of you saying 30 minutes before. What do we think about 30 minutes before? What's the risk of 30 minutes before? What type of insulin is Nova Rapid? It's rapid acting. Is there a difference between rapid acting and short acting? The BNF, by the way, will tell you these. The BNF can tend to confuse you because they all fall under short acting. Yes. So you've got two different types that if you want to categorically simplify short acting insulins, you've got soluble insulin and then you've got rapid acting insulin. Well, what's the difference between soluble insulin and rapid acting insulin? Rapid is faster than short acting insulin. Absolutely. So every time you see the term soluble insulin, that's where that's referring to short acting insulin. And soluble insulin is relatively slower in terms of onset of action, in terms of its peak onset of action. It has a longer duration of action as well. So when it comes to Mrs. Williams, ideally you say directly before your breakfast is absolutely fine because of the fact that it's a rapid acting insulin. Onset of action is relatively quick, 5 to 10 minutes. It already has an onset of action. Its peak is about 1 hour, but it starts to work after 5 to 10 minutes. So in terms of rapid acting insulins, you've got a few different types. You've got Humalog, which is Lispro, Novorapid, which is Aspart, Apidra, which is blue lysine, and Fiasp, which is Aspart. What is the difference between Fiasp and Novorapid when they both contain insulin aspart? Fiasp has a faster onset of action, absolutely. Um, does anyone know why? Faster absorption, faster onset of action, absolutely. So in terms of manufacturers, they're the same. There's an addition of vitamin B3, and this addition of vitamin B3 is what gives it a relatively quicker onset of action. This can be between like 5 to 10 minutes, but 5 to 10 minutes when it comes to you having several meals during the day is a big deal. I'm on Fiasp insulin, and there is there is a noticeable difference between the two. I'm snacking so often. Those 5 to 10 minutes of a quicker onset of action mean a lot to me. In terms of onset of action, it's within 15 minutes generally for considering all of them. In terms of peak, 1 to 2 hours. Duration of action, 2 to 5 hours. It's injected immediately before meals. There used to be a routine where people used to say to have your rapid acting insulin after your meal is absolutely fine to patients. We completely avoid that now. So the routine use of this is completely avoided. We advise patients to have it before their meals, not after. What's the problem of a patient having it after their meals? Um, let's say they don't forget. There's still actually a problem there. Yes, what tends to happen because your peak is 1 to 2 hours, a patient's sugar level will start to go high fairly quickly, particularly if it's a carb heavy meal. And then um, the risk of a patient's sugar levels going higher, um, and then you giving insulin after a meal means you just give an unnecessary 1 hour delay. So that's why it's very important to have the rapid acting insulin before meals. We are going to finish off with this last case. And then the next webinar, I'm just looking at the dates for our schedule. The next webinar where we go through all the more insulins in more detail will be on the 23rd of October. I put that up on the micropharm.org website, so you can sign up to that session. So you can sign up to that session after today. So Zara takes Humulin S for mealtime insulin. When she's due to eat lunch, when should she take her insulin for lunch? Oh, interesting, Julia. She shouldn't take it. Oh, she shouldn't take it before lunch, or oh, sorry. I was confused. So this is where the normal practice is 15 to 30 minutes before food. And that's because Humulin S is a soluble insulin. So it's a short acting insulin, it's a soluble insulin. What are some of the challenges for soluble insulins? No, so really, when someone said take them often in the day compared to long acting, what are some of the challenges when you compare a soluble insulin to, for example, a rapid acting insulin? Yes, you have to. You essentially have to plan to take your insulin 30 minutes before your food comes, which, if you consider how we eat now and expecting Uber Eats deliveries, Deliveroo deliveries, it sounds like a nightmare to me. And you will probably always either get it wrong, or you'll end up resorting to just taking it directly before your meal. And the risk of taking it directly before your meal is your peak after your meal. So your postprandial peak will be higher. So you rather be on a rapid acting insulin. Um, it just makes logistically more sense. So this is where we will stop today's session. I'm going to put a poll function just for your feedback for today, just to see if you found today's webinar useful. And then I will see you on our next webinar is the end of this month, where we'll be going through a quiz style question, going through GPhC style questions. If you want to be up to date with regards to the advancements with the new membership, head over to www.micropharm.org and you can sign up to the webinar. You can sign up to the newsletter, and then you'll be in the know. If you want to sign up to the pro membership this week, before Saturday, before the price goes up, then you can do so on micropharm.uk. That's good to see that everyone found it useful. So thank you everyone for attending. Those that are MicroPharm members, I will upload this recording to your platform right now. So once we've ended this session, I'll download the recording and pop it onto the online platform. Thank you everyone for attending, and I will see you in the next one.
Right, so hello everyone, my name is Nkatia. I'm one of the clinical educators for calculations on the MicroPharm platform, and in today's session we're going to be focusing on doses and dose regimens. I think it goes without saying that, again, this is sort of your bread and butter as far as pharmacists go. I think as pharmacists we get quite het up about doses, and rightfully so. We want to make sure that the doses that we are endorsing and supplying are safe, effective, and appropriate for the patients that we care for. So that is what this session is going to focus on today. So before we get into the nitty-gritty of it, again, what I want to stress is that your success as far as the calculations component of the registration assessment goes really falls down to understanding the questions. Make sure you know your question types, okay? Each assessment is likely to include at least one calculation question involving each of the following in part one. I also want to stress to you that ultimately, as a pharmacist, calculations are not impossible and they will be part of your day-to-day life in many different forms, whether you're in primary care, secondary care, tertiary care, or even a mixture. Remember your time management, you have about 3 minutes on average for each question, so that's more than enough time for you to attempt the question, check your working out, and even attempt it if you're really time savvy. Remember to think about the context of the question. This is not just a calculations assessment. This is a pharmacy practice assessment that is being assessed through the prism of calculations. So make sure that the answer you're giving is practical, make sure it's feasible, and make sure it's what the examiner has asked you for. And finally, highlight parts of the question. Break down the question into smaller, bite-sized bits to make it more digestible, and make sure you highlight keywords so you can understand and focus on the important bits. But that being said, let's jump right into it. So like I mentioned before, doses are your bread and butter as a pharmacist. Okay, we always think about doses. And with these types of questions, it's not uncommon for them to make reference to the summary of product characteristics. My advice would be that if you haven't come across an SPC yet, or you haven't read an SPC yet, read one. They are free to access on the internet, and I would just familiarize yourself with them. And by that, I don't mean you need to memorize every single SPC of every single drug, but what I would say you need to do is just get used to the structure of them, know where to find relevant bits of information. Now, that being said, now since the GPhC assessment is now online in test centers, might I add, The questions tend to almost take an excerpt of the SPC, at least they did when I attempted the assessment. But that being said, you can also use a magnifying tool or a search tool, not Control F, but a similar one that's built in order for you to find relevant bits of information. So to that extent, that makes using SPC slightly easier. But know the structure of the SPC, so you don't have to waste time in the assessment looking for the information that's relevant to you. And with these SPC questions or these dosage questions, you may very well need to convert between different forms. So here's an example, okay? So here we have a 10-year-old, okay, and this 10-year-old is taking phenytoin capsules at a dose of 300 milligrams daily in 2 divided doses. Now he's finding it difficult to swallow the capsules. The doctors approach you and ask you whether suspension is available, and they ask for your help to prescribe the correct dose. It's worth noting here that the conversion factor for phenytoin is 92 milligrams of phenytoin base equals 100 milligrams of phenytoin sodium. Use the resource for this question, and I've given you a link to the BNFC for phenytoin. How many milliliters of the oral suspension should the child take per dose, and therefore what should the doctors prescribe on his drug chart? Give your answer to the nearest whole number. I want you to pause the video, give yourself 3 minutes. When time is up or when you're ready to go through the answer, press play. Okay, right, I think we can crack on. So, this is a really, really important question, and it's really important because if you don't consider conversion factors, you have the potential to cause patient harm. So with phenytoin here, I suppose if you were to give 100 milligrams of phenytoin base, you would be giving slightly more of phenytoin sodium. So you could well push that child into toxicity. If you got it the other way around, the patient could have a seizure because they are not controlled. So these are all things to think a little bit about. So the first thing that I would need to do here is firstly figure out how many mil of the oral suspension to the child take per dose. So what I wanted to do from the resource given was I wanted to find out what the concentration of the suspension was. In this instance, it's 30 milligram in 5 mil, which is 6 milligram in 1 mil. Now the question tells me that the 10-year-old was normally taking phenytoin capsules or phenytoin sodium at a dose of 300 milligram daily in 2 divided doses. So 300 milligram divided by 2 is 150 milligram of phenytoin sodium per dose. Since we know that 92 milligrams of phenytoin base is equivalent to 100 milligrams of phenytoin sodium, we therefore know that 0.92 milligrams of base equals 1 milligram of phenytoin sodium. Now, the reason I did that was so I could figure out what dose of base is equal to 150 milligrams of phenytoin sodium, which is 138 milligram when I times both sides by 150. The solution encompasses 30 milligram in 5 mil, which is 6 milligram in 1 mil. Therefore, 138 milligrams is equal to 23 mil. Now, if you're wondering how I calculated that, I did quite old school. 30 milligrams in 5 mil is 6 milligram in 1 mil. I divided both sides by 6 to find out what 1 milligram was equal to in mil, and then times both sides by 138, which then gave me 23 milliliters, which is a whole number. So in this instance, the doctors would prescribe 23 milliliters of phenytoin base, 30 milligram in 5 mil oral solution twice daily, and that would give you the exact sort of conversion factor between phenytoin sodium and phenytoin base. I hope that question made a bit of sense. Again, remember that we here at the MicroPharm team are here to support you. Keep practicing questions, keep practicing your dosage questions, and I wish you all the best in your endeavors as you prepare for the registration assessment. Right, so hello again, everyone. My name is Nkatia. I am one of the clinical educators for calculations on the MicroPharm platform, and in today's session, we're going to be focusing on unit conversions. This is going to be a much shorter video because there's not lots to say here. It's really just sort of emphasizing the importance of being able to convert between different units. As it stands, you'll come across many different formulations, many different types of medicinal products, and they'll all have different units, and it's important that you as a pharmacist are able to convert between them. Converting between them correctly could very well make the difference as to whether a patient gets an underdose or an overdose. So it's incredibly important that you're able to convert between different units very easily. As I've said before, and I'll say again, your success as far as the calculations component of the registration assessment comes down to understanding the questions. Know your question types. Each assessment is likely to include at least one calculation question involving each of the following in part 1. I also want to remind all of you that calculations are not impossible, and they are part of a pharmacist's day-to-day life in many different forms, whether you're in primary care, secondary care, or tertiary care, or even a mixture. Remember your time management. You have about 3 minutes on average for each question. So that's enough time for you to attempt the question and sort of read it, understand it, go through your working out, and if you're really time savvy, even attempt the question again. Think about the context of the question. Again, remember this is not just a calculations paper, this is a pharmacy practice paper in the prism of calculations. So think about what's feasible, think about what's realistic in terms of your answer, and make sure that the answer you're giving is what the examiner has asked for. And finally, make sure that you highlight parts of the question, break it down into bite-sized chunks so it's easy to digest and understand, and highlight keywords so you don't miss out on the important parts and you can focus on those. But with all that said, let's jump right into it. So really, in terms of this section, what I do want to sort of just list here are the different units that you might come across. So you may come across a situation in which a patient's weight is given in pounds or even stone. And it's important that you're able to sort of convert between the two. That's something that I definitely struggled with. Um, in terms of height, inches and feet is also not uncommon either. So it's really important that you're able to convert between the two. It's also worth remembering your distances, so meters, 100 centimeters, and meters is 1,000 millimeters. I think that really the key ones refer to sort of milligrams, sort of weight or masses. So kilograms, grams, milligrams, micrograms, and nanograms, and picograms, which you don't see very often, but there's no reason why you couldn't be asked a question where you need to convert between the units. And I think really that's everything from me as far as converting between different units. Again, the takeaway message really is just knowing to recognize your different units and just knowing what the conversion factors are between them. Okay. Just remember that the MicroPharm team are here to support you, and I wish you all the best in your endeavors as you prepare for the calculations components of the registration assessment.